part of our Antimicrobial Stewardship Project webinar series, and it's part of our effort and our outreach to expand the topic of antimicrobial stewardship, the role of diagnostics, and antibiotic resistance globally. So we're very excited that Dr. Sugai and Dr. Joshi have joined us this morning from Japan and from India. The title of their webinar today is Awareness or Distraction? Has COVID-19 shown us a path forward from combating drug-resistant infections? Dr. Sugai will be speaking first. He's the Director of Antimicrobial Resistance Research Center, National Institute of Infectious Diseases in Japan. And Dr. Joshi is head of South Asia, the Center for Disease Dynamics, Economics, and Policy. So she'll bring us even this expansive perspective from India as well as Southeast Asia. And I'm your host. I'm Dr. Marnie Peterson, and I'm the Outreach Coordinator for the Center for Infectious Disease Research and Policy, and we are located at the University of Minnesota in Minneapolis, United States. So this webinar is special in that it's providing quite an extensive amount of continuing education for physicians and pharmacists, and the activity has been supported by an educational grant from BD, otherwise known as Becton Dickinson and Company. So I just have a few slides for our listeners before I hand it over to our speakers. And I'll get started here. There's a couple slides. So for disclosures, first and foremost, our CE provider is ProCE, and we're ensuring balance and objectivity and independence in this educational activity. To require all of us involved in the planning and the presentation of the webinar to declare conflicts of interest, and as you can see, no one on our team in this webinar had any conflicts of interest to report, and it was peer reviewed by our on-staff Executive Medical Director, Christine Moore. The educational activity may describe the discussion of published or investigation use of agents that are not indicated by the FDA, and the planners of this activity do not recommend the use of any agent outside label indications. These are the expressed opinions of these experts, these esteemed global experts in infectious diseases, and they have implied responsibility to use the newly acquired information to enhance outcomes. The participants, those of you that have registered, have implied responsibility to use this newly acquired information to enhance patient outcomes in your own professional development. So it's served to be educational and to provide you with the content and information to create awareness around antimicrobial resistance, surveillance, diagnostics. Going on to the next slide. Our target audience are all of you that have signed up, as well as to meet the educational needs of physicians and pharmacists. Our learning objectives at the conclusion of this activity, the learners should be able to, number one, explain how infection prevention practices utilize diagnostics and how improved utilization can decrease the burden of drug resistance infections. Dr. Sugai will be addressing this outcome, really thoroughly describing the center that's been formed in his country and the use of many different platforms and many collaborative groups to guide surveillance and to update their antibiograms and track antimicrobial resistance to change clinical practice. Also describe how to integrate diagnostics into your antimicrobial stewardship programs, how to track outcome metrics. Dr. Sugai will also be speaking upon that. And Dr. Joshi today explained the cross-boundary challenges of communicable disease control in South and Southeast Asia. As I mentioned before, educational grant was awarded to CIDRAP from BD for this educational opportunity. Here's our CE. For pharmacists, ACPE accreditation, as well as ACCME for physicians. 1.25 hours of CE awarded. So this is 1 hour, 15-minute webinar. The presentation will be about an hour, and you'll have about 15 minutes of Q&A to engage with our speakers. There will be, this is a Zoom platform. You're probably all aware how to use that at this point, but there's a chat box and a Q&A section. If you want to write your questions and comments into those sections, I'm happy to moderate for Q&A. And finally, how do I collect my CE? I'll be presenting this information to you also via the chat box and on the slide at the end of our presentation, but you go to this website, which is proce.com. You complete a post-test, an evaluation, your deadline 1 month from today. For those of you, it may be the 26th, so it will be just one day shy of 1 month from today, June 25th. And the attendance code for this, where you can collect this, will be presented at the end. So that's all the information I have for you. And I'd like to welcome Dr. Sugai to begin his presentation. I'm going to stop sharing my screen so you can bring up your slide deck. And welcome, Dr. Sugai. Thank you for joining us.
Thank you. Can you see this slide? Hello, can you see this slide?
Yes. Yes, we can, Dr. Sugai. Go ahead.
Okay. So everyone, thank you for inviting me to give our recent effort in the national surveillance in Japan. My name is Motoyuki Sugai, Director of Antimicrobial Resistance Research Center in National Institute of Infectious Disease, NIID. Our AMR Research Center is pretty young, established in 2017, succeeded the activities of one of the laboratories in Department of Bacteriology 2 in NID, and expanded as a center affiliated around 50 people, including researchers and technicians. Our major mission is AMR surveillance and research, and today I'm going to share with you about the recent activities on surveillance. I am very thrilled and excited to get a chance to share this information with you. In Japan, the government established the AMR National Action Plan in 2016. And the goal of this National Action Plan has six contents, and one of them is surveillance and monitoring. And in the National Action Plan in Japan, they wrote that there are two types of the surveillance, and they are going to strengthen the surveillance of AMR in healthcare and nursing care in Japan. And today I'm going to share with these two types of the national surveillance in which we are involved in. The one is the Japan Nosocomial Infectious Surveillance, JANIS. The other one is the National Epidemiological Surveillance of Infectious Disease, NESID. So start with JANIS. JANIS is a national surveillance program organized by the Ministry of Health, and we are the acting administrative center of the JANIS. JANIS is designed to provide national data of the incidence and prevalence of nosocomial infections and antimicrobial resistant bacteria in hospitals in Japan. And this will help participating hospitals map out strategies for infection control. And this is not mandatory, but this is voluntary-based surveillance. And here, this is an overview of the JANIS. JANIS consists of 5 divisions: clinical laboratory, antimicrobial resistant bacterial infections, surgical site infections, intensive care unit, and neonatal intensive care unit. And the largest and the most unique one is a clinical laboratory division. And the purpose of this division is to measure the resistance rate or proportion among clinical isolates. It is an isolate-based surveillance, but we do not collect isolates itself. We collect only data, information of bacteria isolated and identified and measured its drug susceptibilities in hospitals. We also do not collect clinical information of the patient of whom the bacteria was isolated, and therefore we do not know whether it caused an infection or not. But in this division, we focus on prevalence of AMR, antimicrobial resistance among clinical isolates. So this is a system of the data collection. And each clinical laboratory in the hospital participating in this JANICE submit the data through internet cloud, and the data is automatically converted to the electronic data to JANICE format here, and which include the data, place, specimen, origin, sex, age, identification, and AST result, patient ID. And these data are aggregated in the AMR Research Center in the server. We compare the data from all the hospital enrolled and analyze and publish information periodically. So this is the data feedback data. We have two parts of the reporting. One is the JANICE open report. This is for the public, and which include the quarterly and annually. But we soon stop releasing the quarterly data, only annual data. And for the other one is a JANICE feedback report for the member hospitals. This is monthly, quarterly, and annual report. And the number of the participating hospital is started with less than 500 in 2007, and it gradually increased. And in 2015, JANICE participation has become the prerequisite for reimbursement for infection controls. So from the tax, so this will stimulate the enrollment of the hospital, especially the small hospital, and now it exceeds more than 2,000. And this is representing hospital enrolled in JANICE. So more than 900 beds, a large hospital, and almost 9% are already enrolled. 80% for the 500 to 900 beds hospital. And around 50 is 200 to 500 beds hospital, and only 12% for the hospital less than 200 beds. So most of the acute care hospitals are now enrolled in the JANICE system, but in Japan, we have approximately 8,000 hospitals in Japan, but about 6,000 hospitals are less than 200 beds. So the mixed care and long-term care hospital accounting for that is hospital below 200 beds data. Still, we need to increase the data of this to obtain the comprehensive analysis of all the hospital data in Japan. But even though the hospitals enrolled in JANICE are scattered all over Japan like this, and we are currently accepting around 8 million data from the hospitals, and talking about isolates information, 5 million per year. So we are accepting quite a lot of information from all over Japan. By using these data, we can delineate that the percentage of the facilities reporting the specific antimicrobial-resistant bacteria. For instance, talking about the MRSA, every hospital has an MRSA patient. BRSA, on the contrary, there's no, at the moment, there's no hospital giving the data of the BRSA. And talking about BRE, less than 10% still. We have a very low instance of VRE infection, but 10%, less than 10%. In such a way, we can figure out the rough sketch of the MR status in Japan. And this is a national report antibiogram example. This is E. coli in 2016. So all the antibiogram is written like SIR in the color code, and also the all the necessary antimicrobials used for the treatment of E. coli here. For instance, imipenem and meropenem, almost all susceptible. Less than 1% is carbapenem resistant in 2016 for the E. coli. In such a way, all the bacterial antibiogram can be seen by using this JANICE. And also we recently started collecting data, not only the inpatient samples, but also outpatient samples. Outpatient samples data can be used for the empirical therapy. By using this JANICE, we can figure out the trend of the AMR bacteria isolation rate in Japan. So if you look at the summary here, the MRSA is now decreasing, but the decrease is stopped around 2017, and now it started to increase a bit. And on the contrary, the quinolone resistant third generation and third generation resistant E. coli are increasing. In such a way, we can figure out the trend. The most importantly, our data, we are collecting not only the culture positive samples, but also the culture negative samples, which enables the calculation of the denominator, a total number of specimens submitting patients required by the WHO class. So our data can be compatible with the WHO class. So JANICE feedback report. The merit of the enrollment in this JANICE is to get for the participant hospital to get the confidential feedback report, which provide summary of each hospital data, as well as provide benchmarking data by comparison with other hospitals, actually national hospital data. So this data help map out strategies for infection control at each hospitals. So this is one of the examples of the feedback report here. Left side is national data for the Acinetobacter species. The right side is Acinetobacter species for the hospital K. So one of the hospital. So when you receive this data, comparing the left and right, you will easily figure out our hospital K, has something program with infection control. So this will be the benchmarking and motivation for the hospital K to improve the infection control. Also, each participating hospital will receive this type of the monthly feedback report. After registering the data, within 48 hours, you will get this type of the data, which you will see the box plot information of the each resistant bacteria. So in this box plot, you will see that this red box, red indicator in the box. This is your hospital situation, and this is around the national data. So you are in the midst of the this national data, so it is fine. But if you are in the extremely outside of this hospital, you'll be in trouble, something wrong with your infection control. So this again tells you the situation of the hospital infection control compared to the national data. And so also you will get the information from when this antimicrobial resistant bacterial isolation started, and also in which ward you will start the isolation of such kind of the AMR bacteria in your hospital. So these types of information is very helpful, useful for the improvement of infection control in each participating hospital. And very recently, in 2019, our partner AMR Center, AMR Clinical Research Center in National Center for Global Health and Medicine started a new surveillance system, JSIFE. JSIFE is, as you can see here, the Japan Surveillance for Infection Prevention and Healthcare Epidemiology. This is a so-called integrated database for the infection control. So the national platform, and this will including the trend of AMR from the JANICE data, and also antimicrobial usage data, AUD, DOT, and also indexes for HAI and clinical practice, all data together to feedback to the group of the hospital. And JSIFE is National Surveillance Integrated Database Platform aimed to collect data of trends of AMR, antimicrobial use, and index for HAI and clinical practice to feedback comprehensive data to the group hospital. In Japan, A number of hospitals are affiliated in all over Japan, which comprise large hospitals, small and medium-sized hospitals. And in each region, regional cooperation of these hospitals is strongly encouraged. So for this group, JSHIVE has a group making system, and data from hospital groups are collected to a central server. These data analyzed and visualized will be feedback and shared by regional hospital like this. So these are the data of the JANICE related things, but there is a limitation of JANICE clinical laboratory division. This does not distinguish infection control. So in JANICE data, we cannot distinguish infection and carrier. And also no genetical information about MRO, MR bacteria is available. And also participating hospital is changing because this is not mandatory. This is voluntary based. So now it's increasing. Also, there's another national surveillance in Japan, which is called National Epidemiological Surveillance of Infectious Disease, NESID. This is pursuant to the Act on Infectious Disease Control Law. This is mandatory reporting of infection cases. The notifiable disease include VRSA, VRE, MDRA, and CRE. And the sentinel surveillance was made with MRSA, PRSP, and MDRP. For the strengthening of the NESID surveillance system, when some hospital has an outbreak of notifiable AMR infectious disease, then the data will go to the local health center. And also the bacteria involved in this infection is sent to the local research institute. The local health center is registered this patient information to the NESID, and also the pathogen information such as PCR data or PFG will be registered through the local research institute. So in our AMR Research Center, we have weekly monitoring and risk assessment session every week. And we are uniting this patient information and pathogen information to see whether is there any accumulated increase of the patient by the AMR infectious disease, or some prevalence of the AMR pathogen in some regional hospitals. So if you find some news from the risk assessment, sometimes we will send a message to the hospital or local health center or local research institute to alert. And also in some case, if the hospital needs some help, we will send a FETP, our field epidemiological training team, to support the containment and also taking necessary action in the hospital to support the hospital. Also, our AMR Research Center will generate the genome data from this pathogen, AMR pathogen, to support epidemiological research in the local research institute. So another mission of the AMR National Action Plan is the international cooperation. And we aim to develop AMR surveillance in Asian countries using the JANICE system as an international cooperation. By modifying programs of JANICE system, we built another cloud system in which each country can have a confidential database, submit data, and obtain the national and feedback reports. We called it ASIASnet. It's open source and free of charge. This international JANICE system is collaborating with WHO and closely collaborating with WHONET. WHONET is a free software developed by Dr. John Sterling in Harvard and a WHO collaborating center. I can conduct management and various analysis of microbiology data. It is being used in over 120 countries all over the world and recommended by WHO. Through active discussion with John, he implemented a function to export and convert WHONET data into the JANICE format. We are proposing the combination of HUNET and JANICE as a model of the AMR surveillance in Asia. Clinical laboratories using HUNET generate and maintain data, including disk diffusion test results, and conduct data conversion and submission to the JANICE system. The JANICE system conducts data validation, RIS interpretation, deduplication, and creates feedback reports and national reports. The JANICE system can also create reports to WHO GRAS. So it's free of charge, and a few countries are already trying to do this combination. So right now, due to the corona pandemic, our activities, international activities, is now pending for a while. But after the corona, we are going to again try to implement this in the Asian countries. These are our activities, and thank you for joining us in very early morning in US and Europe. Thank you very much for attention. Thank you.
Thank you, Dr. Sugai, for your presentation. I believe next we'll welcome Dr. Joshi and Dr. Sugai. There you go. We'll wait for Dr. Joshi to begin sharing her screen and begin her presentation. As we're waiting, I just want to, our participants that are viewing this, if you'd like to submit questions or comments to the speakers at this time in the chat box, feel free, specifically for Dr. Sugai, and we'll get to those at the end of the presentation. Dr. Joshi, you ready?
Yes.
Excellent. Thank you for joining us this morning.
Thank you to you, Marnie, and the rest of the CIDRAP staff for inviting me to take this session. And a big thanks to all the listeners in different parts of the world as they are trying to get new information with all the responsibilities we are handling during this COVID-19 pandemic. So welcome to you all, and I hope you enjoy the session. I'll be speaking on understanding the cross-boundary challenges to communicable disease control in South and Southeast Asia. I'm based at New Delhi, and I work with Center for Disease Dynamics, Economics and Policy, a research think tank, NGO, a non-profit organization, which is based in US, but also in New Delhi, where we have offices and work in Asia and Africa. So South and Southeast Asia basically comprise of almost 19 countries, and these include in South Asia from Afghanistan, Pakistan, India, Nepal, Bangladesh, almost 8 countries, and Southeast Asia has 11 countries, which are a large part of the ASEAN, as well as the larger countries in the Mekong Delta, such as Thailand, Myanmar, Vietnam, etc. And totally, these are almost 19 countries. Now, this is a very diverse region which is undergoing a very rapid social, economic, environmental, and even a demographic change. There's a lot of population that we are talking about in terms of human capital, and also migration, which is not just internal within countries, but between countries, and they have very porous borders. Now, this has, makes it a hotspot for very specialized ecological niches and the emergence of new pathogens from this area. So we've seen some outbreaks of like the SARS and the virus, which because of the greater intermingling between the human, animal, and environmental aspects in this region. Moreover, governance of infectious disease control in this region is a challenge. There are different forms of government, and their administration across countries are varied. There's variable surveillance capacity. We've heard a lot from Dr. Sugai about how they are supporting countries in Asia, but the complexity of the countries here, from the large scale and size like in India, and the rural, urban, and even the environmental infrastructure, the tribal and forest covered land, as well as the agricultural increase in land use, is creating a lot of demand on all the resources, and that which makes it a very good niche for emergence of pathogens. with governance challenges and variable surveillance capacity, not just in the human health sector, but also in other sectors, makes it again a very hot spot for emerging pathogen and infectious disease transmission. So human health surveillance capacity, both in terms of clinical surveillance as well as laboratory, is very varied. Some are well advanced, but some countries are still setting up only their national reference laboratory, which are at very high end or tertiary care hospitals. There is more demand, or there's a requirement actually for more research that can inform policy and practice so that interventions can be addressed for specifically those cultural contexts that we are talking of. Besides this, the health services and systems in this area are very unique. You know, they're very pluralistic and fragmented and complex. It's not just the licensed medical providers that we are talking about, but there's a large source of informal or untrained health providers that works in this region, whether it's India, Nepal, Bangladesh, Myanmar, where there's a dependence on the traditional health system, where people maybe have worked with licensed practitioners and set up their own rural practice, or they are licensed in other alternative medicines, but are practicing both allopathy as well as their own traditional systems. Moreover, there's a large private sector which has variable participation in nationally coordinated programs. Now, this is very relevant for the region because most of the infectious disease programs are vertical, or they have a push to be integrated within, to generate knowledge about where the cases are and how they can be handled, rather than being a part of the larger health provision system in the country. So this makes a very big demand on resources, and it is a very targeted intervention for specific diseases rather than for all infectious diseases overall. So there's also a very high out-of-pocket expenditure. Most of the people are dependent on their own for provision of health services. Universal health coverage is great in some parts of the region, like Thailand is a shining example. Sri Lanka is also improving. India has started a universal health coverage program for those below the poverty line with a limit of at least 500,000 Indian rupees for large, very critical measures. But these resources are limited. Moreover, these vertical programs that I talked about have a large focus on disease control priorities rather than primary prevention or promotion of health overall. Not just this region is very fragile in terms of the social determinants of health. There's a dense population with a large part of which lives below the poverty line. Some of the visuals here will show you the demand on the land and other natural resources. There is a gender bias, especially against the female child in large parts of South Asian countries predominantly. And the female participation in the workforce is limited. And where it is very underpaid. That impacts the household income and the ability, the lack of literacy in the females affects the health literacy of the family overall. Moreover, the lack of clean water, sanitation, and hygiene, and the infrastructure that is needed is again something which is worse off in the South Asian region and is a critical determinant of health, which can provide a lot of change in the health systems if that is done on time. There have been interventions in many countries like India, for example, the Swachh Bharat Abhiyan to improve wash and toilet services. And this has had impressions on the health system, but it is largely unresearched so far. There is a very high and increased, in fact, rising antimicrobial consumption because of the access over the counter, and that works against in infectious diseases and prevents them from vanishing from the planet, even though we have vertical programs to eradicate these diseases. So this backfires to increase the burden of resistant infections, as I will talk, and increases the problem even more. Moreover, there is a very high burden of undernutrition in many parts of this region, and there is the rising burden of non-communicable diseases. So in fact, this makes it a double burden disease area, and countries are, with this fragile health system are stretched to provide support services for both communicable as well as non-communicable diseases. Besides, there are social factors, like I was talking earlier of mass movements. Now, migrations within countries, that means internal migration, as well as between these countries in the region and away, is very common. For example, the mass bathing in the Ganges for religious ceremonies is a very precious practice in the Hindu religion and has been found to have been associated with the resistance gene of BLA-NDM1, which is 20 times higher in people who have done this, even just a bath in the Ganges. Similarly, multi-drug resistant tuberculosis has been seen much more in Tibetan refugees in India who are coming from other parts of the world. And this is complicated by both access to health as well as counterfeit or poor quality medicine, so which is also a critical problem, especially in South Asia. The emergence of NDM1, which I have shown in the visual here, started in India but has traveled all over the world. And today, in the flat world that we live in, this social factors become very critical. Similarly, multi-drug resistant typhoid, which has been reported with very high prevalence in Pakistan and now in other parts of South Asia, has now spread to Africa, Europe, and other parts. So in today's interconnected world, these social factors within the region impact not only this region, but those countries that are outside. So these conditions, not just in the human health sector as the system is stretched, but also in the animal sector, as I will discuss one slide on how food security and food safety is important, as well as the environment, the pressure on the land use, and the outfits from the sewage and other aspects to the water bodies and land makes it a perfect ground for breeding resistant infections, and especially relevant for AMR. Moreover, many countries in this region have a very active and vibrant pharmaceutical industry. India is definitely one of them, but also Bangladesh and Indonesia, which again, the effluent from their sewage treatment, from their effluent treatment plants in these factories contributes to the antibiotic resistance that emerges, antimicrobial actually, to all different pathogens. Why this is important? If you see the risk of ESBL or extended spectrum beta lactamase enterobacteriaceae colonization, mind you, not even a disease, but just colonization for a traveler who comes to the region, stays in the best of the facilities with bottled water and food, the chance of colonization in South Asia is almost more than 50%, 55%, whereas it is less in the rest part of Asia, and especially high in India, which is almost 87%. So irrespective of all the safeguards that you've undertaken, you will go back carrying the resistance bacteria in your gut with the potential of transmitting it further. This is also related with the poor sanitation and infection prevention control in the region. Access to toilets is very little in many parts of Asia, as this dot shows from a report of UNICEF, and this contributes to the genetic elements for resistance that are present in both the water as well as the sewage. The most common cause of early onset neonatal sepsis, for example, in India, one of the largest countries in the region, is Acinetobacter, which is a free living organism, but commonly found in hospitals and ICUs because of the poor infection control measures or hand hygiene and reuse of instruments which are not cleaned properly, and is accounting for a large burden of neonatal sepsis. Now, the factors that are impacting this is also the high antimicrobial consumption, like I was sharing earlier. There is easy access to antibiotics, and it is increasing. With such a high infectious disease burden, people reach out to antibiotics over the counter. This is especially high, you can see in the slide, on India, China, Pakistan, and many other countries. And the change in the consumption of access and watch antibiotics, which are antibiotics that should be used in first line for any drug or should be easily available, the access, and the watch category, which is like the antibiotics that should be given with slight caution because the chance of resistance development is high, is very high in the South Asian countries. So there has been a massive increase, and it is increasing further in this part of the world. Regulatory systems are contributing factors, but also the awareness and the behavior of population is a critical factor. again, this access and watch and reserve antibiotic consumption for only the children, in their child appropriate formulations can be seen, the variations can be seen in this slide. In India, you can see that the access group is very little compared to countries like Sri Lanka and Thailand, which have good primary healthcare systems. The access group antibiotic consumption is higher than the watch and reserve. So the stronger the health system and the control over how these medicines are being prescribed rather than over the counter affects the higher consumption and the rise of resistance in this part of the region. Sorry. Now, this is also related with the lack of availability of narrow spectrum agents. It's not just that these medicines are prescribed indiscriminately, which is definitely true, but many of these formulations, which are narrow spectrum with low resistance potential, unfortunately are no longer available in the market. Now, these are supply chain fragilities that the system has. Many drugs like benzathine, penicillin, penicillin G, or dicloxacillin in India, for example, are no longer there in the market. So even doctors who want to prescribe them cannot do that. So the logistic supply chain of these drugs is something that has to be considered. Moreover, there is a tendency for fixed dose combinations, which are not necessarily rational, like I have shown a few here. And they are basically a mixture of drugs as a cocktail given to satisfy the lack of knowledge of the doctor, as well as the demand from the consumer on quick treatments. And when the public perceives the large number of drugs availability as a indicator for good care, this is what results. So these fixed drug combinations are very commonly available, and with the porous borders in the region, they are in fact even carried between countries. But remember, consumption is not always the key driver for resistance. And we have a very interesting study by Collignon et al., which has been presented to understand the impact of different measures, whether it's antibiotic usage or health expenditure or infrastructure. And what it finds is, interestingly, good and very adequate investments in health infrastructure result in a more dramatic decrease in resistance within E. coli when they are standardized. So this is a very clear indicator of what we are seeing today with COVID-19, when we are seeing the numbers rise in the second surge for COVID in India, and the way systems are stretched when they not have had adequate investments in time. Human resources for health in the region are very limited. The doctor-patient and the nurse-patient ratio is on the lowest side, if you see on this slide, where the red lines indicate the mean for the region, and the red dot on the top is the average for OECD countries. You can see that most of the South Asian and Southeast Asian countries also lie in this part. And this again has been unmasked during the second surge of COVID, as I speak here from Delhi. When the resources are low, people are dependent on spending money on their own. And many people who don't have this universal health coverage or social security tend to fall below the poverty line when they have any single disease within the family. Not just that, the critical healthcare capacity within the region is also very limited. Again, this has been very starkly highlighted during the COVID crisis, especially in the second wave, when whether people who have the capacity or didn't have the capacity were racing to get ICU beds. So you can see, for example, the average ICU beds per 100,000 population in India is only 2.2, whereas there are countries which have better bed availability, like Thailand, which again speaks for the investments in healthcare during non-crisis time. Again, the access to antibiotics, like I was telling, is very common in the region and is a factor that contributes to the high resistance rates in the region. But this access is also not available in the regions or parts of the region, where they are needed. Today, more children still die from pneumococcal disease in this part of the world rather than, resistant infections. So till this access and access policy issue is addressed completely, when there is ethical access to antibiotics for all who need it, but the danger of unethical access to those who don't need or demand it is not addressed, we will continue to have a very high resistance burden, and the infectious diseases are nowhere going to go away. Moreover, the wash in healthcare facilities, like Dr. Sugai previously has talked about healthcare-associated infections, which we will trace. In this region where there is limited access to wash within houses, the implications of limited wash in healthcare facilities is even worse. There are poor access to toilets for patients and doctors, less availability of water, running water for hand hygiene and cleaning of instruments, which again contributes to the rise of healthcare-associated infections, which are even more expensive to treat and life-threatening. And this is a vicious cycle because increased HAIs again lead to higher antibiotic use, especially the reserve kind, and with poor infection prevention control and poor wash measures, the transmission of these resistant genes or elements within the One Health sector increases. So, for example, the recent report on wash in healthcare facilities in India showed 1 in 4 lacks basic water services. Now, basic is availability of water, not even running water in the healthcare facility. And only 55% or half of them have access to improved sanitation, which is a toilet with a flush and running water source in it. So it's both a quality of issue as well as an inequality issue. However, there are good signs because there is an initiative, for example, in India, if you would have, on a massive scale led by the Prime Minister to improve the access to toilets within the communities. And this is called the Swachh Bharat Abhiyan. And this mission mode access was expanded to all ministries. So within the healthcare facilities, the availability of toilets and water sanitation was included as a Kaya Kalp, which is a transformative change program. And that has resulted in improvements in some parts, but it is too little, too few, and not too much research has been done to assess its impact. Coming to healthcare-associated infections, like I was talking earlier, there is a very variable healthcare sector, which has a large private sector. Now here, the overall, the bloodstream infections in, for example, in India, the profile here in most countries is very different from what you see in the West. As an example, in India, the gram-negative bacilli cause almost half of the leading causes. They are the half of responsible for almost half of those bloodstream infections, followed by Candida, which is again something that has been exposed here with the second surge of COVID-19, when we have indiscriminate use of antibiotics and steroids. And today there's a crisis for the black fungus or mucormycosis, which has now become a notifiable disease. And the reasons for this high burden is also that the recognition of healthcare-associated infections is very, very late. Remember, there is a very varied surveillance capacity for any infectious disease, and healthcare-associated infections, which will require even more, stronger or a very more expensive surveillance system, where you are tracing not just the phenotypic surveillance, but genomic surveillance and understanding where that element is coming from. When lab capacity is limited, automated blood cultures are not possible. Even triple set sampling is sometimes not possible. And the availability of this test is difficult for people to access. And there's also not being promoted by the healthcare system. It is very difficult to understand the real healthcare-associated infection prevalence in the region. Sometimes the cost of a test is much higher than the cost of the treatment itself. And the easy access to antibiotics makes sure that even a course of antibiotic will treat the infection rather than getting to know whether it was a resistant infection or not. Moreover, there's lack of trained staff, from doctors to nurses to even the healthcare workers for IPC and cleaning. And that leads to a lack of awareness and implementation of IPC interventions, which could adequately address HAIs. There is good news in the sense that vaccines are a good tool to address resistance, and many countries in the region have included already the HIB-containing conjugate vaccines. The access to pneumococcal vaccines, as you can see from the slide, is still limited, but introductions have been done in many parts of the world. Rotavirus vaccine, which causes a large part of the viral diarrhea burden in South Asia, has been included in many countries. and this will decrease irrational antibiotic consumption. Now, outside the health sector, these are the regions which have high undernutrition, so the demand for protein is high, and thus the demand for animal food, especially like chicken or eggs. And unfortunately, the use of antibiotics in this sector has also increased over the last decade and projected to even increase further. For example, I have shown slides for the projections for India, the antibiotic use today, and that projected in 2030. Similarly, in Vietnam, all these antibiotics, mind you, will eventually reach the food chain and the One Health cycle, contribute to resistance and reach the environment and aggravate it even further. Environmental factors, which I have already talked of earlier a little bit, we have to remember that this healthcare system and the sewage system in these countries with the poor wash and IPC facilities is not even in fact detecting resistant genes and its transmission of pathogenic bacteria. So systems are totally inadequate to address this and its interplay with other pollutants like arsenic or heavy metals. Moreover, the rising pharmaceutical industry, like I was talking in India, Indonesia, or Bangladesh, adds to the manufacturing effluents which carry antibiotics and can contribute to resistance. There are reports, for example, in Hyderabad in India, where antibiotic levels that have been found in effluents in water bodies around the pharmaceutical plants are much higher than what would have been consumed in a country like Sweden over a course of 3 days. And the number of antibiotic manufacturers, for example, I'm showing in this slide here, is immense. So only if we see the concentrations, there are regions where interventions can be done, if not everywhere. And that is a direction for countries to address their burden for infectious disease and set up surveillance systems. Overall, at One Health, systems, if you see, are at risk in this region. And the critical gap is in this slide, as I highlight, there is a lack of One Health models or success stories that have been used to combat AMR. Even surveillance systems for how resistant genes and bacteria are moving across the One Health sectors are still not known. The alternatives to antimicrobials, whether in human health or especially in agriculture, that can encourage farmers to drop antibiotic use are still under researched. And last but not the least, interdisciplinary research across sectors, across human and animal health sector, across quantitative and qualitative elements are very few, though growing. And these factors contribute to the large burden of resistance. Now, if I move to considering the time strains, I think to the other diseases in the area, tuberculosis, and especially multi-drug resistant tuberculosis, continues to be very high. And 2 countries, especially India and Indonesia, contribute to the largest amount of the disease in the country. There is good news in the sense the case detection rate has improved in these regions because of a lot of investments in involving the private sector and delivering healthcare of the combination treatment dots through to the patients with even some economic benefits, the direct benefit transfer scheme in India, for example. This has resulted in a decrease in the case fatality rate, which has been especially exciting in India, and these are good times. But the disruptions due to the COVID-19 lockdowns and the effects are going to affect this aspect of tuberculosis control in the region. There's a very interesting modeling that has been done on how TB control in the Southeast Asian region, mind you, can result in a dramatic decrease if there are efforts to either just strengthen, which is just intensify what is being delivered today in terms of healthcare for tuberculosis, or accelerate with some added interventions for tuberculosis, and then prevent by including tuberculosis control, not just as a vertical program, but within primary healthcare. Dramatic successes can be achieved. But still, all of these will be below the dotted line, which is the goal for ending TB in the region. So though things are moving in the right direction, there is still a long way to go. Innovations are needed to tackle tuberculosis, not just in the terms of medicines or systems to tackle tuberculosis, but understanding TB as a socio-cultural issue on why people don't access the therapy completely and why there is a dropout and increase in the resistance, especially multi-drug resistance. So new technologies which are patient-centered are going to be critical. But all of this can then only be revived when the COVID-affected lockdowns and disruptions can be addressed first in all our parts of the world, I think. Coming to malaria, the good news is there are 2 countries in this region that have eliminated malaria, Maldives and Sri Lanka. And it is only 2 countries, India and Indonesia, that contribute to the larger burden, almost 99% of what is there of malaria. However, the region, especially the Southeast Asian region and the South Asian region, has the specialized ecological niche, like I was talking earlier, of development of resistance, especially artesunate resistance in this area. And that is something that we have to be watchful of. Enteric pathogens and especially typhoid are also common because of the poor WASH and IPC systems that we discussed. As the demand for food and the safety of food becomes a concern, diarrheal diseases, and especially enteric pathogens, are something that the world has to watch out for. When most of the world today doesn't bother so much about, addressing enteric pathogens and typhoid because of improved food safety and security, this region still suffers a large part of the same. A large amount of antimicrobial consumption is for diarrhea, which can be easily viral. Thus, inclusion of the rotavirus vaccine within the immunization program of many South Asian countries is going to be an exciting development and should be able to reduce the demand on antibiotics a little more. Coming to a quick slide on what have been the effects of COVID-19 on AMR. The positives have been the recognition of the infectious disease threat, especially the One Health threat, and the push for behavior change even in the common man. There has been accelerated research investments for diagnostics and treatments and vaccines for COVID-19. And the demand to invest in healthcare has become sharper in countries and by governments and NGOs. But on the other side, it has very seriously unmasked the vulnerabilities of our health system, especially the poor One Health system preparedness. Also, the focus with COVID-19 has been on curative care systems, again, at the cost of investments in primary healthcare and universal health coverage, which can be a strong buffer to prevent such emerging pathogens. Unfortunately, antimicrobial use, and not just antibiotics here, mind you, it's both antivirals and antifungals now, as I was talking about the mucormycosis crisis, has been tremendous, at least in South Asia. And we are going to see the effects of it in even the next few years. There has been very late community participation, and the conflicts between the different healthcare systems of medicine in South Asia, the traditional naturopathy and allopathic as well as homeopathic system has unfortunately been expressed even more nowadays. We have to remember health is a state of physical, mental, and social well-being as defined by WHO, not merely the absence of disease. And I think that's what we need to go back on. So just to conclude, this is a very diverse region undergoing rapid change. Health systems are pluralistic and complex and fragile at the same time. The social determinants of health, and especially the social factors that affect access to healthcare and WASH, contribute to a large burden of infectious diseases, especially healthcare-associated infections. And tuberculosis, malaria, and enteric pathogens, all their care services and have been, disrupted because of COVID-19, which has unmasked the health system vulnerabilities in the region. What we must remember is if AMR is seen as primarily a scientific problem, which is limited to labs or hospitals, then and only concerned with drugs or bugs, then it is less likely that people will take the problem to their heart, which we have seen with COVID-19, people have done and have resulted in change. So I think that's the focus for us to think of the cross-boundary challenges in terms of how different countries have responded to AMR. These are the 3 reports that I have used a lot in the slides, and I encourage all of you to access them from our website at CDDEP and see more of the work done on it. Thank you so much for your time and patience. Over to you, Mani.
Excellent, Dr. Joshi. Thank you so much for your presentation. And I do encourage our listeners, whether you listen after this is recorded or you're live now, to visit the website and dive deeper into those reports and your content. I have a lot of questions for you as well. I'd like to welcome Dr. Sugai back as well, just for our question and answer session. And please, those of you that are with us, feel free to submit your questions as well. All right, Dr. Sugai, can you hear me?
Yes, I can hear you.
Excellent, excellent. So I'm going to start with you and go back to the learning objectives. You both so eloquently presented the global perspective, your overall perspective, and your efforts in surveillance and data to present the issues in your approach to antimicrobial resistance and overall health. Dr. Sugai, for learning objective 1, we wanted to talk about how infection prevention practices in utilizing the diagnostics and how that can impact overall antibiotic usage. So I want to step back with some of your slides and take it from this big picture down to how this operates, Janus operates, and then some of the other programs underneath of it. With the samples that come in for these patients, are they being, is the diagnostics that's occurring in the identification of resistance, is that happening at local laboratories, or do those samples get sent to regional laboratories?
No, I cannot understand what you mean. In the laboratory, in the regional laboratory, and the hospital laboratory, what do you mean?
In the hospital laboratories, and then the data gets fed into the Janus system?
Yeah.
Because I thought what was interesting is you talked about how that information comes in and you have the clinicians and laboratorians. So you've got the clinician data with the laboratorians then come together to analyze these data in this group. Is that then a decentralized group that then feeds back to the local hospitals to help them impact?
Yeah, so all the data coming from the enrolled hospitals, and this is accumulated in our server. And after analysis and clearance of the data, and the national report will be sent back to the old, not only the hospital, but open to the public, but also every month, the data of their own hospital will be released to their hospital. This is confidential data. So to the hospital, they can share, the data can be shared by the clinicians and also the laboratories.
I thought that was, very interesting approach, how the data is coming in and you've got decentralized group of experts reviewing the data and then feeding that back. Is that going back to infection prevention as well as clinicians?
The data can be used in each hospital, let's say infection control team. It's up to the hospital. We cannot go into details of the hospital management, but this usually the enrolled hospital can use our Janus data for the infection control in that hospital. So every month they will receive the previous month's data. So they will discuss based on this Janus data to discuss about in which words something happened, or what this kind of information can be obtained from this Janus data. So that's the way that the clinicians, especially the infection control team, will be involved in this management.
And then the information coming in from the local laboratories, the diagnostics information, you mentioned that it can be anywhere from disk diffusion to PCR information.
That's for the notifiable disease. That's for the another surveillance. only for the VRSA or CRE or MDRA. In such a case of infection, it is mandatory for the doctors to report the patient ID information to the local health center. And also the bacteria of the causative agent will be sent to the local health institute. So they will analyze and they can report to the hospital directly. But at the same time, this information can be registered in the NESIT surveillance system. So every week we will watch all over Japan. Is there any increase of the incidence of the appearance of the new, for instance, VRE in such a hospital, or in the region? Is there any prevalence of the CRE in these a few months? So by using this risk assessment, sometimes we will send a message alert to the hospital or region, to the hospital as well as to the local health center and local health institute, for them to take action earlier than expected.
Excellent. Yes, that's exactly where I was going, is the impact of having all that data and being able to track it in such a relatively rapid pace to make those adjustments, whether it's infection control or changes in antibiotics prescribing, is very impactful. With all these different resources, both local and centralized. Dr. Joshi, there's some questions that I wanted to, there's many questions that we could talk to as well about with you. It's interesting when you listen to your presentation, because you wonder at the end of the day, where do you start, right? As you outlay this problem, it seems as if you're saying right now that the overall resistance burdens of the bacteria, do you feel it's underreported right now just because you don't have enough infrastructure and diagnostic tests to really track the overall burden of resistant bacteria in these infections?
Yes, thank you for the question, Marnie. And that's definitely true. Like I spoke at the beginning, surveillance capacity is limited in the region. Most of the labs where they are available are in the tertiary care facilities, which are getting which have the facilities, first of all, to implement such a surveillance, and which may be getting the most complicated cases. So the data that we are currently getting is underreported, but also may not be totally representative of what's happening in the region, because many of these infectious disease cases are first being seen at the local level, which may be, like I said, because it's a pluralistic system, they may be allopathic or evidence-based medicine or not. And then by the time they travel to the secondary and finally the tertiary care facilities, they have taken so many courses of antibiotics already. So we are definitely getting some picture, but that picture may not be representative and may not be capturing all the variations that are happening at different levels within countries. But again, within the region, because it is such a diverse region, there are variations. And I think investments in primary healthcare have shown how valuable they can be in terms of both clinical as well as lab practice. So even if surveillance capacity doesn't exist in a country which has a strong primary healthcare system at the field level, that facility at a higher level will capture a large part of the diseases and their patterns better compared to one country that has not invested. And it is going to see a high amount of resistance, I'm sure, because of even the community access to antibiotics, which complicates the development of resistance in the region. So yes, the picture is definitely still not known, and there is a lot to unravel.
And a follow-on to that is it seems like it's difficult as a clinician when the normal flora, even you talk about babies, I would say their gut flora, maybe it's not normal flora, but it's overall some of the gut flora is already resistant to antibiotics. So, and then it goes on from there. If you become ill or infected or get sepsis, you're already needing to use these extended spectrum antibiotics to try to treat, and you're probably running out of options. So how to stop the cycle? And it's which maybe you can comment on, but it seems like, you know, we're talking about the interplay between diagnostics and antimicrobial stewardship, and antimicrobial stewardship is such a huge component around it as education, and you need diagnostics to inform not only the surveillance but appropriate treatment, such that you can then prescribe those antibiotics, and so there's those aspects. So I guess my question is, where are you at? I guess with antimicrobial stewardship, do you feel that the strong component there is education of the public as well as the clinicians, but then trying to also get the infrastructure to provide some of the diagnostic tools to help with antimicrobial stewardship?
Well, that's a great question. And I think for this region, at least, the focus has to be both creating awareness about the danger of antimicrobial resistance, because, you know, that's unknown. And I have educated and uneducated patients both reaching out for an antibiotic if their cough or cold doesn't resolve within 3 or 4 days, and which for most common reasons would be a viral infection, you know. So that perception within the community here of reaching out for an antibiotic if it doesn't address itself or resolve within a week is something that first we have to tackle, because that creates a demand for even more antibiotics or even antimicrobials, I would say, as we have seen with COVID. So that is one, but at the same time, educating the healthcare providers. And for that, I think what is important is having data and transparency around that data. So stewardship activities have started in many countries here, even if they are few, but they have, and they have shown the value of that, whole investment. But we need the scale, these interventions to be done at scale, and that data to be available for people to see the benefit of, you know, evidence-based medicine, because there are also variations within healthcare providers. Most of the healthcare providers get information only from very limited, associations or councils of their own, but rather it is from the pharmaceutical industry. And that is going to be biased information. And most of the standard treatment guidelines are based on empirical data of what doctors have been, you know, trying and make works for them in one part of the country rather than what is evidence-based. So till the data is published and its value in terms of which antibiotic should be used as first line, second line, how does it impact the resistance profile is available for people to see, only then can we sustain behavior change. So it is a chicken and egg story, but I think without data and transparency, we have nothing to start on. So stewardship activities are very important, and not just in the healthcare system, but also within the community to create that, to decrease the demand pressure on healthcare providers and the community to not indiscriminately use antibiotics. It is an invisible epidemic, you know, I should say it's an epidemic literally, and it's endemic now. So we need to address it with that vigor. And it's being exacerbated by COVID-19. So.
Absolutely. But so good that you presented it in the way that you have. And again, I encourage people to read your reports because there's a lot of information there that's really important. I'm going to share my screen so that our participants can see their attendance code. Dr. Sugai.
Yes.
You mentioned, I'll ask you a question as I do so. You mentioned along the way, as you were, I'm going to try to multitask, as you were working on Janus and getting all this information, that it became important. The other component of this was that you started to include the clinical data and the antibiotic use data into the group. Can you just explain to our participants, I just think this is a really important point, just explain to them as we close out here with this last question and I share the attendance code, why that became important, why you felt you wanted to add those two pieces, the clinical impact and mortality, and what other metrics did you add there, and then the antibiotic use into your database?
Because can you hear me? Because I have introduced a new approach to create integrated database, including JANICE data and antimicrobial use, and also the clinical information. So because of the two discussed in the region of the hospitals, in the regional hospitals, among the regional hospitals, to discuss about the situation of the infectious disease caused by the AMR, only the bacterial information, but not only the bacterial information, but also the antimicrobial use in that region is also important, and also the information of the situation of the HAI incidence is also important. So in such a integrated database may be very useful for the group of the hospital to discuss about the improvement of the infection control in that region. Because in Japan, in the regional hospital complex, including the acute care hospital and also the long-term care facility hospital and the medium-sized hospital, this kind of group is sharing the information, and also to improve the infection control to completely eradicate the AMR bacteria from that region. Not only the acute care hospital, but also the hospitals with low number of the bed, like 200, lower than 200 bed, small hospitals, because sometimes the accumulation of the AMR bacterial patient in the small hospital, then the patient get worse, then sent back to the acute care hospital. This will be the cause of the spread of the AMR bacteria in that acute care hospital. So overall understanding of the AMR attack AMR countermeasure is very important. So that's the reason why the AMR CRC Clinical Research Center established the integrated database, including not only JANICE data, but also other clinical data and antimicrobial use data. Does that make sense?
Absolutely. I just wanted to highlight that. I think that's so important to integrate all those components of data. And Dr. Joshi, at the higher level, you mentioned about consumption and how that can correlate with resistance, but as well as infrastructure and all these other factors. So I think it's important to remember that. And I wanted you to be able to speak to that, to emphasize those key components. We're out of time. I let us go a little over because of my delayed start. But I wanted to remind everyone that this is recorded and will be available, and you can go now if you watch live to proce.com and take a post-test and evaluation for us, as there's CE offered with this. And the attendance code is HTAKR7 there on the screen, and you'll be able to pick up your CE. I wanted to thank our sponsor, BD, Becton Dickinson Company, for providing that education for us. And most importantly, Dr. Joshi and Dr. Sugai, as I know you're extremely busy with a lot of other urgent, important things, but this is so important, and I'm so glad that you're tracking and providing the surveillance to all of us, as we are, as you mentioned, Dr. Joshi, we need a One Health approach. And even a lot of those antibiotics that are produced in India, they're not just for India, they're for the world. So very important that we remember that and how connected we all are. And as you say, that we lead with our heart, and it's important to remember that our health is our well-being overall. So thank you so much for your time and your presentation. Yeah, and have a good rest of your day.
Thank you.
Thank you.